that we use over there. Now, this circuit came with it, and it has, this thing here is a collection bottle. If you had a heated bottle, the water would drain into here. We're now getting, don't have this, so probably won't have it. A lot of ventilators, you have an inspiratory, expiratory. As this ventilator, you just have one flow, which is inspiratory, and then the expiratory comes out the other side, and you have this little rubber thing that releases all the expiratory gases. And the reason I want to show you how to connect it here is one of the alarms that might go off will be low pressure. And low pressure means that you have a disconnect somewhere. So if it goes off, then you're going to look, the first thing you're going to look at is to see if it's come loose from the trach. And if it's still going off and it's still connected to the patient, then you're going to look at the connections to see that we don't have a leak. So you've got 3 tubes here, and it's color coded. The first one just inserts on the little steel nipple. The second one is the yellow. If it comes loose, it screws on. When we place it on there, we always turn it back opposite, counterclockwise, and then that way when we put it on, we have a nice little seal. Same with the white one. So if you get a low pressure and they're connected, check your tubings to make sure that they're connected. Now this other line here, if you have somebody who comes over and they're on oxygen, which 95% of our patients are, at least 2 liters, and we go by, over there, we go by the same flow rate here that y'all do, as y'all do here. If they're ordered at a percentage of oxygen, we just look at, if their prescription says 32%, we put them on 3 liters. We're using concentrators over there. We don't have the piped in oxygen, and I found that over on our concentrators, anything from 6 to 10 liters, because they're 10-liter concentrators, they're usually at 50%. The oxygen adapter is this copper port on this side. So if you don't see it, it's usually covered, but this will fit right on here. So if they come over, which they might transport them on an E-cylinder, make sure you take them off the E-cylinder, just go ahead and connect it to the wall. So,
I have a question for you. You said that most of the time they're on oxygen, sometimes they're on the vent without oxygen?
it's possible.
So just given pressure?
Yeah, I mean, they might have a ventilation problem instead of an oxygenation problem.
Okay.
So it's possible, but the majority of them are usually at 2 liters. This goes in the side here. So that's our vent setup. This part goes to the patient. These are the pressure lines that monitor the pressure. Now, when the patient comes over here from the next door, this is the setup we have them on over here, over next door. This is called an HME. It's a heated moisture adapter. Instead of having a heated unit, this here, as they breathe through it, it heats up, moisturizes the lungs. This here is for breathing treatments, spring loaded. If they come over here and they need a breathing treatment, they're on the vent and you want to give them a breathing treatment, you just take the mask or the mouthpiece off and it'll fit right underneath here. This will be my assistant. So this just pops under. They're all the same size. It just pops under there. If you'll notice it's spring loaded, just make sure that you push it up far enough and tight, and then just connect it to the wall. And that's how we give them our breathing treatments next door. You can leave it connected for the next treatment or take it off. Okay.
Next question. this goes to the patient.
Well, it goes here.
Okay.
I'm just showing you this part.
Yeah, the patient came the other day with this, I was trying to figure out.
Yeah, how that goes.
Okay.
It goes like that, okay? Now, we got this is a flex right here to make it a little, when you got a trach, you know, it's yanking at the throat, so nowadays they've got different stuff, so this is flexible, so it doesn't pull a whole lot of tension and cause a lot of trauma and bleeding, so that's what that's for. Now this is what they call a ballot, or it's called an enclosed suction system. Once you get over here, you want to connect this to your suction. To your suction from there to here. And this has a lock device. And so if you go to press it and you can't suction them, all you do is just lift it up and twist it, and arrow to the arrow, and you'll be able to suction. So, you know, make sure that your suction is set up, your suction is on. And now this is where the trach is. It's going to be right here. And if the other alarm that you're going to hear is the high pressure alarm. So there's going to be two alarms. You're going to have the low pressure, which means there's a disconnect. First thing you look to see if this is coming off the trach. And then the next one is going to be is usually your high pressure. And that's usually what goes off 90% of the time. And that usually means that there's secretions in the airway and the patient needs suction. So in order to suction the patient, you're just going to insert the catheter using the plastic until you hear they'll start gagging and coughing, and that's usually an indication you've gone far enough. You don't need to go much further. Press the knob down and go ahead and suction out. Now, if they have a lot of thick secretions, you're going to get the red ampules of sterile or sodium chloride water. They usually come in 5, 10, 15s. And you have a port here. So what you can do then is you can, don't press this, because when you press this, the water's going to go back this way. Just keep your hands off that, press the water. It'll go into the lungs enough. It's called a lavage. You've all heard that technique. And it'll loosen up the secretions. And then you maybe want to suction it again. Usually 2 to 3 times is usually good enough to remove the secretions from there. Now, after you think that you've suctioned enough and you've got the secretions out of the airway, go ahead and take the remaining water, if there's any left in the little ampule, or you might have to get another. You always want to follow up by squeezing it and pressing this. That way we clean out our line so that the secretions don't remain in there and clog it up. Because when they come over, you're probably, I don't know if you'll keep these on here. You probably don't. So you're only going to have one. So therefore, if this gets clogged, there's going to be a disadvantage. You're going to have to send somebody across the street, or, you know. So the main thing is just like any line that you IV line or whatever, you always want to flush it out. So make sure it remains open.
Did you see the saline goes in the support?
Yep. Right there. And then afterwards, close it off. Okay. Now this is our patient today. This is called a test. It doesn't work with that part, so we're connecting it straight here. Now usually when the vent comes over, it's already going. You have one? Cool.
Back. Wow.
The vent's probably going to be going when we come over. So you're not going to have to turn it off. But if they send the patient out, you're gonna have to know how to turn it off. So this is the on and off switch right here, where it says on and standby. So I'm gonna go ahead and turn it on. Press it, hold it for 3 seconds. Now it's working. Okay. See our patient's breathing for us. Okay, now currently, this patient doesn't breathe on his own. Or maybe, he's unconscious and, he's having a hard time breathing. So we've got him in assist control right now. Now, if you look at this, the facing on this vent, you've got 3 different areas. You've got one that says controls, you've got one that says alarms, you've got scrolling across the top that's telling us what is alarming right now. So this up here is going to tell you, we've got a high pressure that probably is outside. So now this is the silence button over here. So once you hit the silence button, then you hit the select. Now if you hit it again, it should reset. Once I change the it's reset. So anyway, once you hit silence, hit the select, find out what is going on, then it'll reset, the alarm will go off, and then about 15-20 minutes later, if this patient is suctioned again, the alarm will go off again, or you'll get a low pressure. Okay, so first of all, I'm going to go over the controls. You've got all ventilators have the same settings. It doesn't matter what size they are, how small they are. You're going to usually have a tidal volume. You're going to have a breath rate. Now this one, you've got inspiratory time. You've got a pressure support, and you've got sensitivity. Inspiratory time is the amount of time that it's taken to get the volume of gas into the lungs. The sensitivity is what is from 1 to 9, and it tells makes it so the patient can trigger a breath. Usually, if they're a non-COPDer, we usually keep this at a 4. So the higher the number, the more sensitive it is. So now, if the patient's apneic and you want to give them a breath, there's a button down here, you can give them a breath. So each time I do that, I can give them a breath. Now you've got a control lock here. That's mainly for us next door. If you don't want the patient's family, maybe this patient's been at home and they know just a little bit about the vents, and they're like, well, I know at home he was on a tidal volume of 700. Well, I'm going to go ahead, when the respiratory therapist walks out, I'm going to go ahead and change the controls. So we can lock them out if we want to. So that's what that's for. But we're not having an issue with it, so we're not using it a whole lot. Okay, the next control you need to know about here, but I have all ideas, whatever control they come over here in, whether they're in assist control or if they're in SIMD, which SIMD means they're taking spontaneous breaths, and they're probably going to remain in that control over here. So, but if by chance you ever had to change it, you would hit this twice, and it would go to the other side. Now we're in SIMD. Now if I want to go back to assist control, they're not breathing on their own. The doctor wants to, the machine to do all the breaths. Then we switch it back over and put it in SIMD. So, just by hitting it. Now, if we run a blood gas on them and the doctor says